morning, everyone, in the DGF East and Society of Fetal Medicine webinar today evening. And we will be discussing MTP Act 2021 and management of late second and third trimester anomalies today. And we have with us addressing the August gathering, none other than Dr. Sharda Jain ma'am, who is Director of Life Care Center and IVF. And she has been a faculty for 2 decades in PGI Chandigarh and Lady Hardinge Medical College. Ma'am is a teacher of teachers, and she's a founder and Secretary General of Delhi Gynaecologist Forum. Ma'am is a member and expert OBGYN in Ethical Committee of MCI 2018-20, and again in the Medical Council from 21 to 23. Ma'am has been decorated by Lifetime Achievement Award and Living Legend Award by many professional bodies. Ma'am has a passion of teaching for safety of doctors, creating medical legal awareness. Ma'am has been instrumental in educating all the gynae people in the forum for medical legal activities and to enable them to have the latest medical legal updates and so that we can all practice safely. So we hear from none other than Dr. Sharda Jain ma'am addressing the August gathering. Over to you, ma'am.
Thank you, Dr. Meenakshi. And at the outset, congratulations to all the gynecologists listening us for the new MTP Act, and which rightly said by Dr. Jyoti Bhaskar that it has taken 50 years. But we are all glad that there are gems hidden in this new MTP Act, and we must make the best of it. Why the gynecologists were needing all the changes? We all know that we all felt that all malformations cannot be picked up by the anomaly scan, which we will be doing in less than 20 years. This thing, but we certainly know Dr. Khurana is going to highlight more that only 70 to 80% malformations we can pick up with certainty, and the rest we could not. People like us who used to get it done routinely at scan at 28, 30 weeks, we picked up a few, and some were picked up pretty late in pregnancy. So as far as this MTP Act which has come, it has raised 2 issues which always bother me. And one issue which cheers me up, and I'm not going to deal, I think all of you know what cheers us up. There are a few malformations which are not picked up by the gynecologist in spite of the anomaly scan and repeated level 1 scans. And these are the ones which bring litigations. And our the data from our country is available, that in somewhere where you find the faculty which comes to interrogate things finds it like me, I save them, but there are people who get lot of penalty for missing up these malformations. And I think many people are listening, and they are looking forward by my message and to Dr. Khurana. And I feel Dr. Khurana can be Masiha for all of you who are involved in litigations and sankat mein ubharne ke liye yahi kaam karenge. Because we find in Europe and in England, there are 11 malformations which are listed where doctors can miss. Anencephaly can be missed in 2%. Heart diseases can be missed in 50%. Kidney diseases can be missed in 70%. Now, in those cases, once this document is available and the litigations come against them, we place the document and they're all saved. We do not have that kind of a document as far as our country is concerned. So whenever the judges make judgment, they are looking for Indian documents first, which we do not have. And they don't bother to see ki England mein kya ho raha hai, unless there's a big law which is followed everywhere. So at least my sincere request to Dr. Khurana, again, I'm making this request to him with folded hands that he should gear up in 2022, that he should come out as a karta dharta of the Society of Fetal Medicine in India, that he comes out with a list that these are the malformations which can be missed. And I think this is my humble request to him, that he will definitely do this particular job in a time-bound manner in 2022. And I think this is my sincere request. And secondly, which I feel, the panelists will do a great job today, that after 24 weeks, what has to be done. And not only when we talk about what has to be done, the legal part of it, we should be within the frame of this new MTP Act, we should be acting. And secondly, the people who are sitting in the remotest area, say Uttaranchal or my state, UP, they should also have the technique which is 100% will help them in terminating those pregnancies if I decide to terminate at 20 weeks or 26 weeks. So I think, when the panelists are taking those questions, my request is they should not concentrate about the tertiary care hospitals in Delhi. They should consider the remotest person who is sitting there when they are making suggestions, because many people are watching this particular thing. With this particular remark, I think, I'm happy to be a part of this. And I think my colleague, Dr. Achila Batra, is going to speak to you as an AOGT chief. What concerns her? Dr. Achila Batra.
Good evening, madam, and good evening, everyone. You have put it very correctly that we need to know what is to be done for those anomalies which cannot be picked up, and what is to be done if we pick up an anomaly and after 24 weeks the baby is going to be, with cardiac activity. What should be done? So we are also very concerned about these. We had put these questions up to ministry also, and they said they did not have an answer as yet, but they said they are coming up with guidelines. So once the guideline comes, only then we will be able to say that if these things are not included, which we are concerned about, that how the pregnancy is going to be terminated, like in remotest area. And very rightly put by you, what anomalies should not be the part of legal action. These things then we can take up. But I have today personally talked to Dr. Sumita. She was busy, but she said she will try to join us by 9:30, and we can ask her what is the state of affairs now. And definitely Ministry and Dr. Sumita is very responsive, and whatever suggestions we give from AOGD and from DGFS, they would definitely take it up. So let us first know what they have in pipeline, because still we are not very clear what anomalies they are going to list in the list of anomalies. So still that list comes, we cannot say anything. But then after that, definitely, and I think your suggestion to Dr. Khurana should take it as a tall order that he has to by 2022 find out a list of the anomalies which can be missed, so that even Indian doctors can be saved. And I think today's discussion is going to be very, very fruitful. But only thing, my contention is that if we are doing a panel discussion on what can be done, maybe our ideas are okay, but we have to know what the government has to say, because whatever our ideas are, we can come to a consensus, and maybe after that we can talk to them. Till then, whatever we talk about will be just, what we think, and it cannot be, used. So that is what I think, So we'll have to still have a little more wait for things to be very, very clear.
Hello? Hello, can you hear me?
Hello. Yes, ma'am.
Yeah. So I as a chairperson, I think this is a very important topic that we have to discuss, because it is a very practical. It's from the practical point of view that it's important for us. There are not, besides the malformations which we miss, there are a lot of malformations which we can actually detect later on in pregnancy. I still remember that at AIMS, I had actually to tell some patients who wanted a termination of pregnancy late that they could go to UK and get the pregnancy terminated. So it's at one time people used to go abroad to get a bypass surgery. So I think that situation is now with us, that we should be able to do a termination of pregnancy beyond 20 weeks till 24 weeks. The practical problem that is faced is that a lot of women still come in the second trimester for screening, or for biochemical screening, or for even ultrasound. Malformations are detected late. You may be advising them in an IPT. They might be needing an amniocentesis, And by the time you get the reports, it's definitely beyond 22 weeks. So what do you do then? You have in your hand a baby which is not going to be in good condition, and then you cannot even terminate the pregnancy. So I think this CME on late second trimester, especially be up to 24 weeks, and also what legal actions we can take for pregnancies diagnosed with fetal malformations after 24 weeks. I think it's very relevant, and I think this topic is going to be extremely important for us today. Thank you very much.
Thank you, ma'am. Thank you for the inputs. We move on with the first academic session of the day. We have a talk on the topic late second and third trimester anomalies, a relook in the context of the recent MTP Act 2021. We have a speaker, Dr. Ashok Khurana, and the chairpersons for the session are Dr. Ashla Batra and Dr. Deepika Deka, ma'am. I will just briefly introduce Professor Ashla Batra, ma'am, is currently president AOGD. She is from Safdarjung Hospital, and she is president in Archie Delhi chapter 2018 and 20, and chairperson Gynaecologist Committee AOGD and Rural Health Committee AOGD, and honorary secretary AOGD 2015 and 16. Ma'am is an ex-editor of AOGD, ex-editor of Narchi, and coordinator of Foxy Critical Care Conference and Yuva Foxy Norjon in 2018. Ma'am is a dedicated PG and UG teacher for more than 35 years and conducted research projects for LSTM, ICMR, and Indo-US projects. And ma'am has authored various books in Ops and Gynae and several original research papers.
Thank you, Meenakshi. I think
yes,
that's very kind. That's very kind of you.
Welcome, ma'am, in the webinar. And the next chairperson we have our Dr. Professor Deepika Deka, ma'am. Ma'am is a senior consultant currently in fetal medicine and genetics in Cloud9 Hospital, Gurgaon. Ma'am has been president of Delhi Gynae Forum, Dwarka. And ma'am has been former professor and unit head of Ops Gynae and chief maternal field medicine at All Indian Institute of Medical Sciences. And she was vice chancellor in SS University of Health Sciences in Government of Assam. And ma'am has been director of AIMS Kalyani, Kolkata, West Bengal. Ma'am has been past president of Society of Fetal Medicine and past chairman of Genetics and Fetal Medicine Committee in Foxy and past chairman ISOPAP, Norchun. And ma'am has various...
I think we can, Dr. Meenakshi, we can proceed.
Yes, ma'am. So I request Professor Ashla, ma'am, to please introduce our esteemed speaker, Professor Ashok Khurana.
Thank you, Meenakshi. Thank you for those kind words. And it's my pleasure and honor to invite my friend, Professor Ashok Khurana, whom all the gynecologists, not only in Delhi, but all over India, know him for his expertise in, especially with the fetal medicine. And he is a chairman and consultant in reproductive ultrasound of his own lab. And he is a professor, School of Health Sciences, and he's past president of the Society of Fetal Medicine, former International Society of Ultrasound in Obs and Gynae ambassador in India, editor-in-chief for Journal of Fetal Medicine. And we all know his expertise in fetal medicine. And whenever we are in doubt, there's always, okay, let's get it done from Dr. Khurana, and he'll tell us exactly how it is. And he's doing such great work, and he's looked upon by everybody in the field of gynecology and in ultrasound. And I'm sure his inputs on the second and the third trimester anomalies is going to be of immense help to everyone. So over to you, Dr. Khurana.
Thank you very much. And thank you, Dr. Ashla, for those very kind words. And my thanks to Dr. Deepika Deka for that introduction, and also to Dr. Sharda Jain for her guidance. Since we met a few days ago and discussed the same subject, you'll be pleased to know that we've set up a Society of Fetal Medicine Committee, which is going to give out a position statement. So once we have a national academic society giving out a position statement, then it truly becomes just like an RCOG or an ACOG guideline, and that is more than sufficient. We're not going to keep it extensive. We're going to keep it a single-page statement, which will be something easy for the legal profession to understand, and especially for the non-legal members of the consumer forum. And we have set ourselves a deadline, and we will have this list ready by the 20th of January, 2022, not even until the end of the year. So, and we've already started our homework on it. And so that's going to
Special thanks, sir. Special thanks.
My pleasure indeed. And I'm so glad you gave us this input. We put it into immediate effect so that the sooner the better. And the question of taking it to the government, well, just like we took the MTP Act to the government, we realized that we had to push it ourselves. So 10 years ago, we were number 600 as far as the bill was concerned in terms of being in Parliament. And Dr. Nozir Shariar at that time was the Secretary General of FOXI at that time, and also part of the, he was chief actually of the FOXI MTP committee. And he first pushed these modifications, and I was working with him at that time to push these. And then after that, Dr. Pai and Dr. Jaideep Malhotra took over and gave it the final push at the ministry level. And we realized that our biggest problems were with the NGOs who refused to understand what we were doing. But thank God, we were able to convince Dr. Shumita Ghosh to be with us on our side, and she understood the problem very well, and we finally had this new act, which Dr. Harshvardhan put forth himself through the Rajya Sabha when we thought we may get stuck up at the last moment. So we now have a beautiful act that is already in use. We already had guidelines before this, but the act makes it much simpler, and I will highlight what we have achieved, because every day, really, in and out, we see things like a microcephaly, which we don't pick up at the time of the anomaly scan. We see chondroplasia, which cannot be picked up before 26 weeks. And we pick up duodenal atresia, like you see over here, which truly we pick up only when the fetus swallows enough. And the fetus swallows enough only after 22 weeks. So we no longer are stuck with that. And so we finally have the rules that have been framed. The act was actually passed in February, after which the committee sat down and made the rules. And the rules really make it very clear on how we are supposed to approach the whole problem. And we know that, yes, this is important because we've been looking at this sort of a problem for a long time. We do know that there are late second and third trimester anomalies, and this list is from Dario Palladini's textbook, which clearly says there are so many that would be spotted, in fact, after birth, never mind the ones that you would spot much later in pregnancy. And these include some pretty common things: achondroplasia, like I said already, a vein of Galen aneurysm, fetal tumors, renal cystic disease, some diaphragmatic hernias, bowel atresias, and a large bunch of cardiac anomalies, including the genesis of the corpus callosum, which sometimes you may not pick up until 22 weeks of pregnancy. And we've had information on this through lots of papers in the literature over the last few years. And we realized that we really had to move in a direction where the wisdom of these papers had to be put forth. And the final push came from this paper, which was from Kypros Nikolaidis' group, where we had the suggestion that, look, in the assessments that we do at 35 to 37 weeks of pregnancy, we do realize that the incidence of fetal abnormality was as high as about 2%. And although there was a bunch of these which had been diagnosed early and the patient had decided to continue, there was 7.4% of that 2% that were detected for the first time postnatally, and almost 1/4 of that 2%, that means 0.5% of those were detected for the first time at 36 weeks. So obviously there we had to give our patients some choices. In Germany, patients have a choice. In the UK, patients have a choice. In several parts of the Soviet satellite states, people have a choice. And we thought that we must let our patients also have that choice. After all, they do get the sort of medical help that we are willing to give them all the time. And so the first thing that we did was that, okay, we will categorize these abnormalities that we see and then go step by step. So we do understand that there will be some patients who've been well investigated, and even though we spot an omphalocele in the first trimester, they've continued because the genetic evaluation was normal. There were good prognosis features in this. It had only the liver, it didn't have too much of bowel, and it was a small omphalocele. And sure enough, after birth, this fetus was operated. The child is doing extremely well. Then there is, of course, that group which are the truly missed abnormalities, where either as a matter of chance or fetal position or not following a protocol, we are not able to pick up things like neural tube defects, And that, unfortunately, is a failure of the profession. But we know that nobody is 100% accurate, and we have enough papers to highlight that as well. And then there is this group, like cystic kidney disease, enlarged echogenic kidneys, which will never be picked up except in the late second trimester or in the third trimester. And then a very important group where the anomalies evolve during pregnancy. And therefore, what we truly see in this situation is the fact that, okay, we have one chamber of the heart, the left ventricle, which is echogenic, which is small, non-contractile, adynamic, and this is critical aortic stenosis. It would be somewhat manifest if you happen to do a Doppler evaluation of the aortic valve at 26 weeks, but there is no protocol in which we do that, and therefore this is something that will show up only later. So that group is the one that we have to particularly look out for and say, yes, this is what we will spot when we do our routine growth scans. And then, of course, some where the insult is late, that either an infection has taken place or a vascular incident has taken place where there's been an infarction. And therefore, then you realize that you will have findings that will show up only in a third trimester scan or in a growth scan done after, say, 30 weeks or so. So having realized that, we realize that there is this huge number of abnormalities that will not be picked up, and therefore we needed to do something about them, and the MTP Act really took this into consideration. And it's not that this was happening only in India. Even in the great registry in Europe, which we call the EuroCat registry, we realized that there are some excellent centers, including those in Paris, where a large number of abnormalities would be picked up either not at all in pregnancy or would be picked up very late in pregnancy. And the one thing that we've become aware of is what we call the physiological, the embryological timetable, where you have certain structures that appear much later than this particular time. And what are these? The cerebellar vermis in the cisterna magna might not be picked up adequately at that time. The corpus callosum appears later. Microcephaly cannot be picked up before about 24 to 26 weeks. Skeletal dysplasia is usually the non-lethal ones will be picked up only after 26 weeks. Bowel atresia would depend on when the fetus starts swallowing, which again would be about 24 weeks onwards. Obstructive urological disease might not manifest itself until as late as 32 or 34 weeks. Restrictive cardiac lesions will always be a third trimester diagnosis. And then, of course, the tumors, vascular and inflammatory changes that I mentioned. And therefore, we realize that beyond just simple embryology and realizing what the 20-week scan would be the end of everything, we would be able to see structures only A, when they are formed, B, when there's appropriate fetal physiology, that things do evolve, and if the underlying etiology is something that manifests late, yes, as I repeat again, this will be picked up late. So where do we stand now? The good news is that the legal termination is now possible up to any time in pregnancy when we are looking at anomalies. In the 1971 Act, we had it only up to 20 weeks, and in the modifications in 2021, we can now terminate this at any time. But I will show you what are the rules and how it works out well, and how best we are supposed to be handling this. And then, of course, the panel will take this threadbare and we will have answers. Importantly, we kept in the background the fact that this was fitting in with the United Nations Sustainable Development Goals on ensuring healthy lives, and specifically goals 3, 3.1, 3.7, and 5.6. So within that, then these sections were added to section 236 and a new section 5A to the original Act of 1971. So there's a lot that was left over from the original Act, and these 4 sections have been added, and this is what I will specifically discuss because this is relevant for us today. So we have amendment to section 2 of the Principal Act, which said that there will be the word insertion of medical board and termination of pregnancy as clauses A and E respectively in section 2. And this means that the states will actually constitute medical boards because, you know, health is a state subject, not a central subject. And all the union territories will also do the same thing, that we realize that if you diagnose substantial fetal irregularities Then the medical board will examine these and give instructions. Then there is amendment of Section 3 of the Principal Act, which sets out to increase the gestation time limit and allows termination possible by a registered medical practitioner beyond 20 weeks, but not exceeding 24 weeks. And it permits abortions on several grounds, which we will discuss. And then, of course, there are amendments in Section 6, which says that which is the category of women who can actually take benefit. And truly speaking, the important thing was that originally in the Act, only a married woman could seek termination. And that was really something that was more, I think, something missed out when the Act was being put together. And thank God that has been corrected, because every woman should have the right to decide what her body is going to be subjected to. And this was becoming very important, because we do realize that when I look at the amount of abnormalities that we, in general, and this is world data, pick up when we were stuck with an early scan in pregnancy. That means when I had a 20-week limit, I wanted to do my scans at 18 weeks, I was going to be picking up only between 50 and 60% of abnormalities. Compare that with what I can do now at about 20 weeks, where I pick up 70 to 80% of abnormalities. So the first implication of this Act is that the routine mid-trimester anomalies scan, old-fashionedly called the level 2 scan in most parts of our country, can now be shifted to a 20 or 22 weeks window, which has a higher detection rate. This will still leave us the old window we had of about 2 weeks, and now even more, because we can go all the way till 24 and even beyond 24 in particular situations, for second opinions, for counseling, for multi-specialty consultations, and further evaluation with genetics where required, with an MRI where required, and other lab tests as necessary. And so even if genetic evaluation takes us a while, and you move on to not just the first year genetic testing, you move on to a second or a third year testing, and the result goes beyond 24 weeks, the medical board will still give permission to say that, yes, this is an abnormality where the quality of life of the fetus is going to be in danger, and decide that, yes, this patient will be given permission to terminate that pregnancy. So that no longer hangs around as a sword on our necks. Then we have implication 2, which is about the level of termination. I mean, at what stage of pregnancy can we do it? So the new week limit is 24 weeks. And this clearly says that fetal malformation that has a substantial risk of being incompatible with life, or if the child born may suffer from such physical or mental abnormalities to be seriously handicapped, then all you need is 2 medical practitioners to allow this, and you can terminate up to 24 weeks, and you don't require court permission, and you don't require board permission. So we know that in the old Act, we required 1 practitioner up to 12 and 2 practitioners between 12 and 20. Now we have 1 practitioner up to 20 and 2 practitioners for between 20 and 24. Very straightforward, very easy to understand, and certainly no argument that this can be seen in any gray zone. Then we have the other portion, and that is that for when we go beyond 20 weeks, and when we go even beyond 24 weeks, then we stop having the permission of just within the profession being able to take a decision. And then we realize that that goes on to the board. But between 20 and 24 weeks, there is just a Form E to be filled up. And that Form E is something that is a very simple form. It's a 1-page form, easy to fill up by you and me. And it's all that is required for terminating that pregnancy. So you and your colleague and a Form E is all that is required, provided you have the skills and the situation. The immediate question that arises, where do I get a copy of Form E? And the second one is, where do I get a list of the permitted fetal malformations? Both of these are very clear, and you could either get them on Google, or you could get them on the Ministry of Health and Family Welfare website, or the Government of India website. And of course, you will also find them on the Society of Fetal Medicine website, which, as you see here, is www.societyoffetalmedicine.com. So when you are stuck with this situation, this is nothing that we have to wait now in the future. This is already here. So tomorrow, if you have a lethal abnormality and you are sitting at 23 weeks, you can decide on your own with a colleague to sign that Form E, and you are absolutely straightforward allowed to do that termination of pregnancy, provided you can give requisite care. Now, the next thing is that in the third implication comes from Section 3, which says that beyond 24 weeks of gestation, the whole matter moves to what is called a medical board. The medical board is something that is constituted by the government and should consist of the people in the board is a gynecology department, radiology department, pediatrics, and any other specialist in that department, and you could include counselors there as well. And then they will come to a conclusion. If necessary, they might ask for additional investigations. And importantly, the medical board will fill out something called a Form D, and this has to be done within 3 days of receiving the patient's request. So the patient or her representative can petition the medical board, and they have to give that permission within 3 days, and they have to ensure and give directions that the termination of pregnancy will happen within 5 days of the receipt of that request from that particular patient or her representative. So the law no longer remains ambiguous. There is a time slot there, and we don't have to wait for weeks and weeks for the legal process to happen. What they refer when they talk about 3 days and 5 days is that this should be working days, and all working days are all days of the week except the second Saturday and Sundays, of course. So there is no question of getting worried about that. Now, the other thing that we have to understand is that there's one clarity that we are still seeking from the ministry, and that is that, yes, we have to get permission from the state medical board, but what is the address of the current state medical board? And we know that some of the states have not appointed this board as yet. While we are waiting for that, for the state medical board, I have received a notification from the, well, not a notification, but a communication from the ministry to say that in the meanwhile, we can put a writ petition in the district court or a writ petition in the high court. Technically, a writ petition can only go to the high court, and a petition can go to the district court, and they can ask their local civil or district hospital to put together a board. So the medical superintendent of the district or civil hospital puts together the medical board consisting of the gynecologist, radiologist, pediatrician if necessary, and they will then decide that yes, permission can be given. So while the state medical boards are being constituted, you can get permission through a writ petition in the High Court or an appeal to the district court. The rules of 3-day and 5-day will still apply to this whole situation. So that then brings us to our daily practice. What do we do? Late anomalies. How can we prevent a detection of late anomalies? Well, the most important thing is that you stop doing ultrasound scans, which doesn't make sense. Why should a radiologist or a practitioner of fetal medicine or a practicing obstetrician stop doing it? What we have to do is go through these, which I will take you through briefly, and they will be also discussed in a lot of detail in the panel discussion that follows. So we'll go through aspects of what we refer to as damage control, which means we prevent further wrong experiences for the patient to go through, for any tragedy to the patient to go through, etc. We will talk about the spectrum of these anomalies, the legal considerations with the patient options in particular situations. Also, how to assess prognostic factors in this group of late onset anomalies, prognosticating future pregnancies, which is very important. And in that particular pregnancy, we will discuss to what extent we will help in improving the outcomes. So that is what we will discuss for the rest of the evening. For primary prevention, of course, there is this tragedy of saying, look, stop obstetric and ultrasound practice, which makes no sense. The important thing is if we follow the protocol of an 11 to 14 week scan, which is not only an NT scan for aneuploidies, but also for structure of the fetus, we will get good answers. We ensure that every patient is offered a good anomaly scan between 18 and 22 weeks, preferably at 20 weeks, so that we can pick up more. And they should be done by people who have appropriate equipment and appropriate expertise. We must follow an appropriate protocol, and we know we have ISWAG protocols, SFM protocols. We also have the option in all these protocols of what we call an institutional protocol, which means that an institution recognizes the fact that they have either lack of number of experts, lack of equipment, or an overwhelming number of people wanting that facility. And then they just put in the institution protocol, and this ABCD is what we will see. If you want more, please go elsewhere. Then, of course, we must clearly mention what are the limitations of such a scan and patient-specific limitations such as oligoamnios, or such as patient habitus, or as fetal position, advanced gestational age, must be documented in the report so that at one glance we come to know that yes, this is something that we will go through. It also gives me great pleasure to welcome Dr. Sumita Ghosh, who has now joined us. And I'm so glad because she was really the prime mover in putting together the guidelines that we used to use until the Act came through. And then, of course, with her support, we've been able to now sustain the concept of the medical board. And I will be eternally grateful to her on behalf of all the women of this country for giving them this right to their own bodies. Now, the other thing that we must realize is that if you're not happy with the scan, we must ask for a second opinion. And then we openly discuss with the patient. From your point of view, it's important as a clinician to keep your indemnity insurances high and up to date. But most importantly, counsel before a scan, counsel during a scan, and counsel after an ultrasound scan, and preferably with the whole family concerned, because that is the unit in our country is not a patient. The unit in our country is not the couple. The unit is really family. So in case there are things to be discussed or something in the family history that needs to be discussed, then that should be with a much larger group, and it should be part of our protocol. The protocols are available, as I said, free on the internet from various situations. And let me go on to a few examples before I close this discussion. The first bit is that look at this mass, which was really very tiny. And if I wasn't on a high-end machine, I might have missed it. And if I did, then what do I do? Well, when this patient does come to me later, I assess the level of the lesion, where I count back and say, okay, this lesion is located at about the lower sacral level. I can see a termination of the cord, which seems to have come down all the way, as you see the top left image. And I seem to think that the cord is ending somewhere at the lower lumbar level, whereas it should end at the L3 level. I notice that the cord has tethering bands into the meningocele, and therefore this then becomes a cause for grave concern because the prognosis is poor. The chances of hydrocephalus are 100%. Weakness of both lower limbs as the child grows is 100%, and failure of the entire urinary system in terms of neurogenic bladder and chronic renal failure would therefore be starting to happen by the age of the third or the fourth decade. So that's a poor prognosis pregnancy. And although we have this background of going into the genetics of it and seeing what it happened, well, that is something we must do. Genetic consultation, go into the history of teratogens such as the anti-epileptics or the antidepressants, the anti-acne medication, and so on. And then realize that also there are non-genetic causes for this kind of a thing. And we must also include the background of diabetes. Having gone through all of that and looking for associated abnormalities, one would review the family history and teratogen intake, do a genetic consultation, discuss quality of life issues, work out whether an MRI might give further information, arrange a pediatric or neurosurgery consultation, a rehab consultation, or even if you can get on-site all these specialists on board, that would be nice. Or we could do it virtually as we've done in the COVID era. Then a medical legal consultation. And this is where the protocol changes, that the patient now has, after all of this and understanding the problem, the option of a late termination. Previously, there was no question of late termination. We had to accept the destiny of the family and the destiny of that individual, and delivery would take place at a tertiary center. And then we would consider folic acid in future pregnancies and that would be the way. But now we have the option of late termination, and that is something that we can do. Another common example, agenesis of the corpus callosum. We know that this is completed only by 20 or 22 weeks, and therefore we might not pick it up. And we go through the same thing, associated abnormalities, family history, and MRI when we diagnose it, a genetic consultation and invasive testing. And then, of course, we realize that this has a variable prognosis. Yes, we can suspect this problem even in the first trimester, but a complete diagnosis comes only after all of this. And again, after a multi-specialty consultation, we realize we have that option of late termination to be offered to the patient. Of course, we realize that yes, in an isolated agenesis of the corpus callosum, we must tell them the truth. And that is that, look, if it's isolated, 90% chance of poor prognosis and 10% chance of 90% chance of good prognosis, 10 of poor. But we may not pick up all the associated abnormalities. And therefore, I cannot give you in black and white what the statistics are going to be. And therefore, then she has to decide accordingly. So that option of late termination then comes here, because the patient might opt to say that, no, I don't think I want to continue with this. And a mother now has a right to do so. She herself on her own can say, look, I don't want this pregnancy, and it can be at any stage of pregnancy. The same thing is with the late onset pregnancies of the bowel atresias, the duodenal atresia, which we often pick up only at 26 weeks or even 28 when we pick up polyamnios. Again, we look for associated abnormalities, cardiac abnormalities, evaluate for trisomy 21, and then offer a late termination. Apart from late termination, as we will discuss in the panel, there are some other options, but the late termination has to be offered at this stage so that she can make a choice. Now, what are the other situations where we have to be a little more sensitive to what is going on? One is this, that when we talk about achondroplasias, these are people who are intellectually completely normal. They have a physical abnormality, and they have the tendency towards lumbar canal stenosis as they grow older, which is pain and increasing disabilities. But the true physical disability is not so much as a psychological disability of being a short-statured individual. Now, here, yes, our diagnoses are made late, almost always after 26 weeks. And yes, in certain pregnancies, we can offer in the next pregnancy, for instance, NIPT for the FGFR3 analysis. But what do we do in this particular pregnancy? Are we supposed to accept termination of a pregnancy only on the basis of the fact that this will be a physical disability without an intellectual disability, and that the patient can actually grow up and have a job, go to college, etc., etc.? Well, this is where we have to draw a balance between patient choice, the fetus's right to life, and the mother's right to acknowledge or not to acknowledge the tragedy that is the Indian community, where for us a physical disability is something that we will say, okay, I will not get my child married into that family, or I will look down upon somebody with a physical disability as someone who cannot be accepted. Now, that is something that is completely tragic, and therefore this business of quality of life issues, maternal rights versus fetal rights, is something that will have to be always considered along with all the cultural considerations. So this does become a gray zone, but again, it's the question of counselors to sit together, of doctors to sit together with the patients, specialists to sit together, the medical legal aspects, and then make sure on who gets the right. Does the fetus get the right? Does the mother get the right? And what are the true quality of life issues? The same thing happens in urinary dilatation. We are able to give you a lot of information. Where is the obstruction? We then put into effect a risk stratification based on protocols that are available. We go on to say that, yes, indeed, we can look back at the first scan and say what the prognosis is going to be. But when it comes to doing interventions, we actually realize that just putting in the psychoamniotic shunt doesn't seem to work. But the answer seems to lie in utero endoscopic valve ablation, for which the window is very early. That window is between 18 and 22 weeks. So what if we miss that window? The outcome is poor. And therefore, we realized that, yes, this is where you give the option of late termination. Yes, but some of them will manage on their own. The ones that manage will manage on their own, not because of us in fetal medicine intervening. So here again is a situation where we have to realize that the quality of life issue needs to be considered. Then there is cardiac anomalies. Yes, we spot an anomaly, patient decides to carry on, no problem with the genetics, and then we make sure that the child gets born, where we keep the ductus arteriosus open with the help of prostaglandins, and that seems to work. But we must realize that the quality of life issues come into the circulation right away. And that is that, yes, although we can give hope to patients with aortic stenosis and an evolving hypoplastic left heart, or we have a pulmonary atresia with an intact ventricular septum, what do we do? Well, the question is, they may not have a good quality of life, and what would the parent want? Yes, in some patients, we've done some salvages with mitral valve dysplasias. We use sirolimus for rhabdomyomas and so on. But the large number of situations which we don't seem to understand is that inherently neurological developmental abnormalities can be present in cardiac abnormalities. And this is something that the patient should be aware of. Yes, we can even say things like, okay, if I have a vein of Galen aneurysm, I will embolize that. But will my fetus have an intact outcome? No. And therefore, again, the parents have to be counseled and say, look, again, quality of life issues and what would you like to do? So the take-home message here would be that, look, our job is to ensure a complete workup of each finding, ensure that associated anomalies are excluded. We don't limit the use of technology to come to a complete diagnosis, and we can take multiple opinions, MRI and genetics. We should know the natural history and outcomes. We must have a working knowledge of surveillance and treatment options. We must facilitate specialty consultations for these patients, be aware of quality of life issues and assess the preference of the couple, and then, of course, perinatal care in these special situations. But the trick lies in counseling, and the option of late termination. And I know this will be adequately discussed in the panel discussion. And thank you so much for your attention.
Thank you so much, sir, for the exhaustive talk, and it very nicely elaborated various situations which will come in, which needs proper counseling and multidisciplinary management. And I request the chairperson, Dr. Deepika Dekar, ma'am, to please make a comment.
Yeah, yes, yeah, right. So I think we have laid the base for which we can now have the discussions. I think it's pretty late now, and we could even I can see there are a lot of questions in the chat box, and then the panel discussion is coming up. Certainly, Dr. Khurana, as usual, this has been a very, very elaborate and a very clear description of what is going to come and how we could all be prepared for the changes after the act is in place. So I think we could now go in for the chat box, or we can go directly to the panel, and Dr. Achila might have something to say.
I think a wonderful talk by Dr. Khurana, and I think the list of anomalies, if like he had said, if they're there, then it is very good. And we also have with us, Dr. Sumita has joined. So I would want if she wants to give any comment on what Dr. Khurana has talked about, or anything else she wants to say. Dr. Sumita?
We are all eagerly looking forward for her statements.
Thank you. I am rather glad that I can listen to your such erudition and discussions. Dr. Khurana's presentation, I could catch only the last few slides. So that a new act has come and the rules have come. We are doing our best to give clarity to each and every issue, but the limitations are there, that not much experience is available, not much expertise is available. So we'll be learning on the way. So don't expect that everything will be very, very clear now. So that is my point, that we are also learning, because this has never happened. The beyond 20 weeks, the expertise is really, really limited in our country. Even head of the departments of medical colleges, when the courts used to tell that this has to be, opined upon and the actions have to be taken for late terminations. Even head of the departments of some medical colleges will also call up that we have never done it, what to do, how to do it. So, yeah, challenges are there, but the intentions are very clear in the Act that if in case the fetal anomalies are incompatible with life, or there is very, very serious probability that the child, if born, will be very much physically, mentally, or otherwise. The words are, that substantial. So, a lot of responsibilities have been put on us, and we must have, and already because of the court cases, we have a list. Dr. Deka is here, so she knows, and Dr. Khurana also was part of it. We have the list, but again, we have to be very, very careful and cautious that, the real intentions behind this, liberalization of the Act. Actually, those cases which are really have a very, very little chance to survive, or very serious chance of being handicapped. So those things are to be decided upon, and I would like to listen to the panel discussion and the issues that are coming up because of this opening up these new vistas. So what will be our challenges? So I would like to listen. Thank you very much for letting me in. Thank you.
But Dr. Ghosh, it would be very important to know, when are we going to be able to do it? When is the Act going to be implemented?
It is already implemented.
No, I mean, we have to still get the orders.
No.
Rules are there. It is gazetted. So you are free, once it is in the gazette, you are free to do.
Once the gazette is out, you can start.
It is enacted, and the rules guiding it have also been, declared, defined. So it is for all. Yes, boards are there. I could see some questions. We have some 174 boards already, medical boards in the peripheral. Mostly, it is only in the medical colleges in all over the states. Yes, the least of that is the states have given us. But again, each state has, sometimes they change, sometimes they, make modifications. So the list which we have, we can share. But again, it will be the duty of the, concerned practitioner to confirm with the states where the boards are. Basically, a lot of boards are there, and only I think one state is yet to come out with a defined board, but others all have. So it is there in plenty. But again, the guidance note on boards, we have already prepared. But like listening to you, so many new points, finer points come up. So it is in shape. So it will be soon be given to the states, and the boards will be gazetted.
Thank you so much, madam. And I hope you will stay with us for the panel discussion, because we have a lot of questions in them where I think to answer those questions.
Yeah, sure.
Great. If you could just stay for another half an hour to 40 minutes with us.
Thank you, Dr. Sumita, for joining, asking you so late, but you agreed. That is so nice of you. Thank you very much.